A very good morning to everyone. So, so I would like to begin our session on nuances of cataract surgery in various corneal pathologies. Uh, we know that cataract surgery may require modifications and additional considerations in case of coexisting corneal disorders. So that the chances of post-op visual outcomes and overall patient satisfaction increases. I would like to invite Dr. Sagar to present on cataract surgery in post-refractive surgery patients.
Good morning, everybody. At the outset, I'd like to thank Dr. Mona for this opportunity. So I will be speaking on cataract in post-refractive surgery patient. As we all know, a post-refractive surgery patient coming for cataract is always a challenge in terms of how to do an IOL calculation for the patient, what type of lens to implant, and sometimes difficult scenarios in during the surgery. So we'll cover these aspects. So we'll cover these aspects during my talk in brief. So whenever a patient comes to you with a history of undergoing refractive surgery, it's very important to look at the pre-refractive surgery refraction and the vision of the patient. That will tell us whether the patient was having indeed any amblyopia. And once the patient has undergone post-refractive surgery, check the spectacle cylinder and the axis and the best corrective visual acuity, because that will tell us the quality of vision that the patient was enjoying. And of course, if the patient is on contact lens, we need to discontinue lenses for at least 1 to 2 weeks, depending on the lens that the patient is using, so that we get the correct biometric values. Clinical examination is important. Ocular surface has to be evaluated very thoroughly. Any evidence of dry eye should be treated beforehand, because we all know that dry eye will lead to poor K estimation and eventually poor IOL power measurement. So this has to be optimized perfectly before doing any measurements. So investigations would basically mean the patient should undergo an optical biometry. That's preferred because all these formulas have been standardized for optical biometry. Topography is must for any patient who has undergone a refractive surgery, and sometimes you would need special investigations like aberrometry, and we'll see why. So optical biometry, most of the current generation optical biometers have post-refractive surgery mode. So make sure that is activated before doing the measurements. And in patients who have undergone RK, we all know that there's a diurnal variation in the corneal curvature in these patients. Being flattest in the morning, that's when we would like to take the measurements, so that we get the maximum possible IOL power. So do we need to repeat it in another biometer is another question which gets frequently asked. So yes, you should do it if you are planning for a toric IOL, and Dr. Douglas Koch actually came up with this nice guideline which tells us that how do you actually decide which patients you should do toric IOL. So this is a simple guideline which says that the patient should have regular bow tie corneal astigmatism within 3 millimeter zone. The difference between the two optical biometers in terms of the corneal astigmatism magnitude should be below 0.75, and the difference of astigmatic meridian should be less than 15 degrees. Let's see an example. See, this patient had measurements from IOL Master 700 and Lenstar, and you can see that the axis difference here is 13 degrees and the magnitude difference is only 0.54. So this is an ideal patient where you can take up for toric IOL. But you see this topographic map of this patient. So not every post-RK or post-LASIK will have a regular bow tie astigmatism. There will be really some element of irregular astigmatism here, and in a very extremely flat cornea, it's difficult to pick up bow tie. But what you can do is you check the spectacle astigmatism of this patient from the old record, and this was consistently the reading, and the patient was actually indeed reading 6/9 before the cataract formation. So we went ahead and did the surgery for this patient and had a good outcome. So what is the role of topography? So topography is very important in these patients because of these things. We'll come to them one by one. So basically it will tell you what is the ablation in that particular patient. We all know that if this decentered ablation, there is a chance that the patient will have increase in higher order aberration, especially coma, which would mean that the patient will have poor visual acuity post cataract surgery. So this has to be warned to the patient beforehand. Again, the IOL power calculation may not be that accurate in these patients. Even if you have a centered ablation, you look for the regularity of the ablation, and this is possible in pentacam when you actually look into the holiday report in pentacam where you can actually see the corneal power distribution curve in the zone that you need to measure. And if you get a regular, if the surface is regular, you'll get maybe a 1 or a 2 peak max to max and a nice plateau. But if you have an irregular surface, as you can see here, you can see multiple peaks. So here is the chance where you might get actually a refractive surprise, because you never know which points are being measured for the IOL power calculation in these cases. Now, some of the topography gives us input for the ASCRS calculator also. So like ISIS, Atlas, then you have OCT and you have pentacam. Especially in pentacam, you get this value, that is TNP apex at 4 millimeters, which is used for LASIK calculation, and PWR-SF people, which is used for RK calculation. So you can get that input from that, and this is the power distribution map from where you get this input. Now, a very useful display is pre-cataract, pre-op cataract display, which gives you these two values, which is corneal higher order aberration and corneal Z40 or Z40, which is basically spherical aberration. So any patient who shows higher increase in total higher order aberrations more than 0.3, 0.5, you are basically looking at higher irregular astigmatism, and these are the patients who are not really fit for EDOFs and trifocal lenses. And of course, corneal asphericity we'll just understand with this slide. So when the next question comes is that most of our lenses are aspheric or non-aspheric. What would you decide? What would you put? So if you have a myopic LASIK, we all know that you will have higher positive spherical aberration. So in these cases, you can put an aspheric IOL which has a negative spherical aberration, which will basically reduce the spherical aberration. And in hyperopic LASIK, to start with, it has a negative spherical aberration, so you would not want to put an aspheric IOL, but an aspherical IOL or an aspheric aberration-free IOL can be implanted in these patients. Sometimes you need additional investigation. This was a patient who had a LASIK about 15 years back, had a regression, and was complaining in the right eye, glare and halos. But in last 1 year, he further had decrease in the vision. On slit lamp examination, he had earlier nuclear sclerosis. You see the right eye map, the left eye map, both shows a slight decentered ablation. Now, what the dilemma is, what is causing the decreased vision? Which component is more? So if you look at the left eye, so in these cases, eye trace helps. So you can see the left eye, all the aberration values are well within the normal range. So the left eye per se, the quality of vision is quite okay. This is how the E looks in left eye, but you see the right eye. Now you see the lens-based aberrations are also there, as well as the corneal-based aberrations are there. So that means the patient will have poor visual acuity in both those things. So this is the lens-related the aberration, this is the cornea-related aberration. So even if you do a cataract surgery in this patient, the cornea is irregular, you will have poor quality of vision. In such cases, probably you would do a corneal treatment first, regularize the cornea, and then do the cataract surgery. EDOFs and trifocals in a post-refractive surgery. So we have to ensure that the patient had good quality of vision, especially night before the onset of cataract, if you're considering these lenses. Post-hyperopic LASIKs should completely avoid putting these lenses. We have to check that the ablation is central, higher order aberration is below 0.5, and any coma or trefoil in their absolute value should be below 0.3. IOL power is another big topic, but conventional biometry fails because of multiple errors. I'll not go into details. And as a result of that, we have close to 30 plus formulas. Luckily, we have ACRS calculator, which has actually checked and ratified a few formulas in their website. And now you also have inbuilt formulas in different biometric machines, as you can see in the list out here. So in ACRS calculator, if you go through, you can have to basically fill up all these proformas depending on the data that is available. So if you have a pre-LASIK data, you can fill up all this data, post-LASIK data, and then of course biometric data. And this he'll calculate. One important point to remember is if you are inputting refraction, the cylindrical value, even if it is 0, has to be inputted as 0, otherwise you will not get the value. So these are the formulas which are available on the ACRS website, where the pre-op data is not available, and when the data is, when there is no data which is available. So in general, the methods which does not rely on data works better. And of late, now we are basically looking at certain other methods which are helping in better IOL power calculation. In this total cataract from IOL Master 700, which basically incorporates both the anterior and posterior corneal curvature and combines it with the inbuilt barrier Truque, is showing results. So this is the same patient showing 19.5 and 20 when you check with TK and K. And now the formulas which basically combine TK with Barrett or EVO or Haggis are showing slightly better performance than just plain K value or Barrett through K. So that is one thing to keep in mind. Artificial intelligence has come in cataract surgery, and in this you have in post-LASIK you have only one AI formula which is available online, that is Pearl DGS. Just to show an example, this is a patient where we did a post LASIK. This Pearl DGS is showing us a 0.7 when we decided to put a 7 diopter lens, and Barrett True K was showing 0.14. So we went ahead with the 7 diopter and we got a post-op spherical equivalent of 0.35. So these formulas do work. RK, Dr. Bhaskar will be covering, but just in very brief, generally you need to target RK patients a little myopic depending on the number of cuts that they have. This is just a last case which I just want to show. This was a patient with an axial length of 35 millimeters, and the A-series calculator gave us the value of around -5 to -7. So we took the maximum value of -5 diopter sensor, which we decided, and this was the small video which I'll just show you the video. It's a 40-second video. So you see the level of difficulty that one has in dealing with such cases. You have a huge central scar. This is a one-eyed patient, other eye lost because of RD. Usually in these cases we don't do a clear corneal incision. A scleral incision is always preferable, and these incisions will open up. So depending on the number of incisions that open up, we obviously have to take the sutures. CTR was used because it was a large bag and we wanted to stabilize the lens. And finally, the 3-piece lens is being implanted, and you can see one more incision opening up, which was duly sutured. There was a third incision which opened. Ultimately, the patient did well, got an ambulatory vision of 2/60, and in the post-RK patients expect hyperopia initially, and there will be a myopic shift and eventually stability in next 3 to 6 months. So I would sum up by saying that post-refractive cataract surgery needs more detailed evaluation. Methods for IOL power calculation are becoming better. Definitely, we are able to predict better now. Choice of IOL would depend on multiple factors, and surgical steps in RK will need modification. Thank you so much.
Thank you, Dr. Sagar. I would now like to invite Dr. Bhaskar for his talk on cataract surgery in eyes with PK and RK.
A very good morning to one and all. I'll be speaking on cataract surgery in PK and RK and the challenges. No financial disclosures. So basically, when you're looking at RK eyes, Sagar did cover it. What's the problem? The problem is basically the significant central flattening that is there, the irregularity that can be there. It could be associated rarely even with ectasias. You have an unstable wound which can gape as you make your incisions. You are dealing with a high myopic eye, so your chamber might actually be deep. Your scleral rigidity will be less, and all this with the issue with your IOL calculation, you might end up with a post-operative IOL surprise. As far as IOL calculation is concerned, the reason for the error is the inaccurate keratometric value. You have an an erroneous ELP if you're going to be using, say, a formula like SRKT, which uses the corneal curvature as a surrogate for ELP as such. It's already a multifocal cornea, so it becomes very difficult, especially if it's not a very well-centered RK, for calculating the IOL power. And post-operatively, there is a bit of edema of the incisions, so it takes a little bit longer for your refraction to stabilize, unlike a regular cataract surgery. So when you're planning for a cataract surgery in an RK eye, the first and most important step is to look at the topography. I mean, it's okay to put the values in the ACRS calculator, but the most important thing is you need to know how accurate your values are going to be. If your topography is regular in the center, you know you're going to be close to the intended target. But if you have a decentered flattening, then you know whatever you're doing, it's like a hit or a miss kind of a calculation, and you need to be aware of that and tell the patient subsequently. And if it is like what Sagar showed in terms of an irregular decentration, then you might even consider regularizing it with some kind of a laser ablation and then planning for a cataract surgery. Obviously, a detailed retinal evaluation is important. With respect to the cornea, before you plan the surgery, you need to know the number of cuts, because you need to decide whether you are going to be making a corneal incision or you're going to be making a scleral incision. So if you have less than 8, you just have, say, a 4 incision RK, then you can even make a corneal incision. But if you have 8 or a 16 mm cuts, then you would probably want to make a scleral incision as such. If if you're making an incision in whether your side port or your corneal incision has to be such that the width is within the cut margin so that it doesn't cause a rip-off of the RK incisions. During the surgery, your bottle height has to be low because you're dealing with a highly myopic eye. Incision length can be a little bit smaller because if the chamber deepens, then you will have a lot of distortion. Already the corneal scar and the central haze will make your visibility a bit of a challenge. So distortion of the cornea will make it more difficult. And initially you might, if you end up say on day 1, day 2, if you're doing a refraction and you end up with a slight hyperopia, you will actually end up plano post-op. If on day 1 you are actually plano, you will end up about a 0.5, 0.75 myopic at about a month's time. So the stabilization will probably take about a month. So, so this is just 2 eyes of the same patient. One eye has had a cataract surgery done elsewhere and has a corneal decompensation, and we need to now decide whether we want to do an EK or a PK. And the other eye has had cataract and we've just operated the eye. What's important is to look at the topography. So you're evaluating the patient, you look at the topography. Here luckily it's fairly centered. Endothelial counts were good, so at least that part of the cornea is taken care of. It was easier for us to get a value as far as what is the ACRS value was similar to your IOL master value also, and we said okay, we'll go ahead. We actually did a modified or an advanced monovision lens, and she's ended up at 6.6 with a 0.5 myopia at 1 month post-op, and she's N10 unaided. So it kind of, we reached what we aimed for, and this was essential because it was still a reasonably regular topography. So once you have a regular topography, it's a lot easier. Now this eye has only 4 cuts, but there is an ectasia. So now this makes calculation a lot difficult because the cornea is completely bizarre, and the patient is using contact lenses. So the decision was whether we want to do a PK with a cataract surgery, but the patient doesn't want a doesn't want a PK or an LK. Patient is happy to continue with contact lenses. So at least to that extent, I'm okay. Even if my calculation goes haywire, she's going to be using contact lenses. But you still want to be as close to your intended spectacle calculation. And luckily, we aimed for about a 9, and she ended up with around a +1 with a -2 cylinder. So it was more here when we actually calculated, every formula was giving us a different value ranging from 6 to 15. So the only good part was I had done some calculation about 2 years back, and the other eye, when I had operated, the other eye was bang on target. So I kind of said, okay, I'll take the value which is closest to the other eye, because both eyes to begin with had a similar refraction. But having said that, this ectasia is progressing, so I would still have been hitting in the dark, not knowing what I'm targeting. So this is another interesting case where patient had an RD surgery, post-RK patient, had oil and needed cataract surgery. And topography was reasonably regular, so fine, surgery went on fine, absolutely fine. On post-op day 1, sorry, 1 second, where is it not coming? What happened? Yeah. So on post-op, sorry, day 4 or 5, the patient is saying vision is very poor, and I just got, I could see a distortion in the cornea, and I just asked them to get the topography. It is showing a significant astigmatism pattern now, because the wound was, sclerotomy wound was leaking, so they've really tightened the sclerotomy so much that's induced the significant astigmatism, almost about 10 diopter of astigmatism, just by trying to tighten the wound to leak. Since it was a leaky wound, I didn't want to remove the suture. Anyway, it was a vicral suture. I said, okay, let's wait for a month, it will kind of stabilize, and it kind of stabilized in a month's time. So if you're doing a combined surgery, you might need to tell your VR colleague that you might want to be a little bit gentle with the sclerotomy suturing as such. So this is a video, thanks to Mona for the video. Why is it not playing? So this is a cataract surgery in an RK. So you can see the multiple number of cuts. So it's a lot, but you need to really plan your incision width, so that you don't extend into any of your RK marks. This patient also had a trab, so the space that you're working with also reduces as such. Once your incisions are made, the difficult part is primarily the calculation and the incision. So once these two are done, unlike Sagar's case, which had a large bag, which had a bit of a zonurodialysis because it was highly myopic. If it's not as bad, you might be able to get away with a regular cataract as such. Obviously your axis has to be reasonably large enough, ideal size, and then the surgery gets over. If there is a gape of the wound, you might want to take a single suture, or you would want to take a lasso suture all around to kind of make sure that your incisions don't open up as such. So it's important to realize and be ready with this when you are starting your surgery. Otherwise, in a normal phaco, you might not need a suture, so your staff might not keep it, but in these cases, you can make sure that you keep it ready. Coming to post-PK cataract, obviously you need to decide on the IOL calculation. So again, if it's a fairly regular topography that you have, great, you might even consider doing a toric lens. Only caveat is, if this graft fails, then you will have to do only an EK. If you're going to be doing a PK, then you have to change the lens based on your standard K. So if you're putting a toric lens, you have to then be more proactive if the patient develops a graft rejection and you're planning for a repeat transplant. You would ideally want to remove all sutures, wait for about 6 months for the corneal topography to stabilize, and then do the surgery. If you have a very large graft and you have taken say 11 or 12 sutures are under the conjunctiva, they are not loose, you might probably go ahead with a cataract surgery if it's a total cataract without being too worried, because those sutures which are so far away will not cause issues with your IOL calculation, because the effect of the sutures so far from the center will not cause a change in your refraction significantly. You would take all measures to protect the graft, which would be a dispersive viscoelastic, obviously an in the bag phaco emulsification, and you would want to avoid a PCR at all costs. You don't want to increase the time that you're spending in the anterior chamber. If you're putting a toric lens and there is a difference in the axis of astigmatism and your topographic astigmatism, like Sagar said, you will probably go back to what vision the patient had and how close the topographic axis and the refractive axis matches. If there is no match, then you will not put a toric IOL. If there is a match, you can go ahead with the toric IOL even if you don't have a regular bow tie. If the patient was using contact lenses for best vision prior to cataract surgery because of the graft being irregular, obviously he will continue to use contact lenses post-operatively unless you address the irregular astigmatism either using a topo-guided treatment or resuturing the graft and then planning cataract surgery subsequently, or combining a PK or an anterior LK to reduce the astigmatism with the cataract surgery. So this was a patient who had a fungal keratitis, a patient with PACG who presented with perforation. We did a therapeutic graft. The chamber was very shallow, so we actually had to do a pars plana limited anterior vitrectomy to kind of make sure that the chamber is formed in the early postoperative period. And this is almost now 8 years. After this, he had a cataract surgery after about a year, and this is almost now 8 years post the cataract surgery. His only eye, he's maintaining 618 vision. So this was a patient who had a PK. Patient was a patient with atopic keratoconjunctivitis. Somebody had planned an LK, but it ended up with a PK. So PK part was fine, sutures were out, but she has a shield cataract. So we went ahead and did a toric IOL. So it's not a very regular bow tie, but it was kind of matching the refraction that we had, and we went ahead with a toric lens, and she ended up with a 0.75 SIL, improving to 6.6. This was a patient with a keratoglobus where we've done a large diameter limbal sparing LK, and then subsequently went ahead with a cataract surgery. This was again a patient who had very severe myopia, so the axial length was around 34. So this is a patient who had macular dystrophy in both eyes. We did a PK in one eye, we did a DALK in the other eye. So this was an eye where we had done the PK first, had a recurrence of the dystrophy in the graft, but it was not so bad that I needed to redo the procedure. He developed cataract. So the question was whether I would want to just repeat the PK along with the cataract surgery, which would have made my life a lot more simpler in terms of visibility, but the patient did not want to get a PK done. So then you use all measures to improve the visibility, trypan blue, light pipe, make sure that you coat the endothelium because you don't want the endothelial cells to be damaged. So using a light pipe or a chandelier will kind of give you the ability to see the capsule more clearly. The most important part is probably going to be, because the cataract itself is not going to be the challenge is your axis. Once your axis is done, then to a large extent it becomes a lot easier as far as this eye is concerned. So So here we did a stop and chop where we got a groove, cracked it, and then once that is done, then it's like any routine phaco. So the staff has to be smart enough to keep holding it. You might want to switch off the microscope light completely so you're able to see it. Or the option would be to put a chandelier at the back so you get some kind of a retro glow, but that will be a pars plana entry, or you'll have to keep a chandelier in the anterior chamber. But even if you keep a chandelier in the anterior chamber, it just gives you a light in one direction. It doesn't give you the same illumination that you get when you place it at the limbus. So even coating the surface with a viscoelastic will actually improve the visibility because of the magnification becoming better. And these other safety parameters in terms of a dispersive viscoelastic, reduced phaco time, in the bag phaco. Maybe flax would probably be an option because it takes care of multiple things in this situation. So you get your excess, you get your nucleotomy done. It becomes a lot easier. Obviously the cost is going to be an issue in that as such. So to conclude, you need a very good proper preoperative evaluation. The ACR is calculated both for LASIK and RK, seems to work reasonably well. When you're operating any of these eyes with endothelial compromise, you will need to protect the endothelium with all measures to get a good predictable outcome. Thank you.
Thank you, Dr. Bhaskar, for such a wonderful insight. So I would like to call Dr. Aditi, who will talk on cataract surgery with corneal degeneration.
Very good morning to everyone here, and thank you AIOS, thank you Dr. Mona for making me a part of this, including me in this course. I will be speaking on cataract surgeries which are performed when there is a coexisting corneal degeneration. So we will be dealing with a few topics, of which the first one is Salzmann nodular degeneration. Now this is a rare non-inflammatory, slowly progressive idiopathic degenerative disease of the cornea that is characterized by bluish gray kind of nodules, which can be seen either as discrete ones or it can be seen in an annular form. The clinical presentation is variable, and the nodules can be asymptomatic or cause foreign body sensation, photophobia or epiphora. Now the pathogenesis is thought to involve poor epithelial protection. So whenever there is anything that is causing a chronic surface kind of change, then there is a disruption of the epithelium Bowman's, and the epithelium derived growth factors go inside and inside the fibroblast to secrete more of the extracellular matrix. So that is when there is the development of these nodules. Salzmann nodular degeneration, the diagnosis is based on clinical examination, and topography is helpful in evaluating the contribution of the nodule to visual impairment. Now, what is the challenge when we are doing a cataract with a patient who has Salzmann nodular degeneration nodules either in the periphery or in the center? These are fairly easily treated, so you may have to counsel the patient regarding the possibility of sequential surgery, in the sense that they may need the superficial keratectomy first, and after that, once the surface is stable, although there is some amount of Bowman's irregularity which remains even afterwards, even after removing the nodules, so the patient should be counseled that they may need a sequential surgery. This is a video showing you the superficial keratectomy, which can actually reduce the induced hyperopia and the astigmatism which is caused by the elevated peripheral nodules. The epithelium is removed, and the trick is to find a plane between the nodule and the Bowman's so that the entire thing can peel off, and you can then leave a smooth surface. And this improvement in the corneal contour allows more accurate and reliable keratometry for IOL power calculations. In fact, in one of the patients, permitting approximations, the required IOL power changed by a magnitude of 13 diopters following superficial keratectomy. So that is the extent to which these nodules can affect the keratometry and the IOL power calculation. So the refractive correction should be investigated before you plan your cataract surgery. And once the lamellar plane is identified and you're able to peel off the nodules, along with their conjunctival adhesions. Then you can apply MMC soaked sponges to the periphery where you are expecting a recurrence of the nodules to occur. So that will reduce the rate of recurrence. A multi-layered AMT can be applied at the end, so that gives you additional protection and additional smooth healing of the epithelium, so that eventually you want a smooth surface to calculate your IR power calculations. So this is what you get by adopting all these measures. This is the pre-operative appearance and the post-operative appearance. Now, like we just mentioned, superficial keratectomy can be combined with other procedures which will reduce your recurrence rate. So either you can use alcohol to loosen the epithelium, or you can couple it with an amniotic membrane transplantation, or you can use mitomycin C 0.02%. And if the patient is unwilling for all these procedures, and if it can be replaced with a simple PROS lens and give symptomatic as well as visual impairment, then you can go ahead with that also. This is a patient in whom we had performed a cataract surgery with a brunescent cataract and implanted him with a toric intraocular lens. A toric intraocular lens because the nodules were in the periphery, and although the nodules were not removed, there was only a 0.75 or 0.5 diopters of astigmatism. Next degeneration that we are dealing with is the Tyrrhen's marginal degeneration. This is a slowly progressive peripheral ectatic disorders like all the others. So it is characterized by a triad of peripheral stromal thinning associated with lipid deposition at the advancing edge, and there is neovascularization. So there is a superficial conjunctival vascularization advancing onto the corneal thinning. By definition, the epithelium remains intact, and the degeneration may lead to high degrees of against the rule or oblique astigmatism. So two types have been documented, an inflammatory form and the non-inflammatory form, and both of them are characterized by this oblique against the rule astigmatism. The important point with Tyrrhen's is that perforation can happen with either spontaneously or post-trauma. So these patients have to be advised regarding protective eyewear. So cataract surgery in Tyrrhen's marginal degeneration, you can first of all, you have to determine whether the regeneration is stable, because if you're hitting a moving target, the degeneration is also progressing, and you're doing the cataract surgery also, then that doesn't work. So in fact, CXL corneal cross-linking has been described as a promising method to avoid keratoplasty and to preserve and restore corneal structure. So you can achieve visual rehabilitation either by scleral contact lenses followed by a wavefront guided PRK. In one of the patients, in one of the case reports in literature, a sterile corneal perforation has been described while doing cataract surgery in a Tyrrhen's marginal degeneration at the area of thinning. This is a video of cataract surgery in Tyrrhen's marginal degeneration. So as you can see, superiorly, it may, in atypical cases, the thinning may be there inferiorly also. So surgery as such is a little bit of a challenge. The more of the challenge is calculating the DBR and calculating the intraocular lens power. So you aim your side ports, you aim your sections away from the sites of maximal thinning. You use all the techniques which have been already described to protect the endothelium and to improve visibility. Limbal sections are preferred rather than the clear corneal ones. And cataract surgery, other than that, is fairly straightforward. This is the way that the cylinder reduced, and the vision rehabilitation was very gratifying for the patient. Improved from a counting fingers to a 6, almost a 6/6. These are the pre-operative. The sutures, the section was closed with a couple of sutures. So in this patient, the DBR was calculated by a multiple of techniques with the auto K and the penta. Thankfully, they were all coinciding. So finally, the penta K DBR was taken, and the patient was implanted with the appropriate lens. So it is important to consider the location of the wound placement and the optimization of the surgical view, the two challenges when you're doing cataract surgery in a patient with any kind of marginal degeneration, whether it is Tyrrhen's, whether it is pellucids, whether it is spheroidal. So spheroidal will also follow the same kind of rules that we followed when we were operating the Salzmann nodular degeneration. Now the next degeneration is a PMD, a pellucid marginal degeneration, again an idiopathic, non-inflammatory non-hereditary, usually bilateral disorder, which presents with asymmetric thinning. The onset of the disease is between 20 to 40 years, but it can cause severe visual deterioration because of the against the rule astigmatism. The zone of thinning, like we know, the area of ectasia is cylindrical rather than conical, and the ectasia occurs just above rather than inside the area of greatest thinning. Corneal topography classically shows the butterfly pattern. So these are the methods by which you can actually stabilize the surface for the corneal problem as such, not regarding the cataract surgery. So these are the techniques that have been described in literature for dealing with the ectasia. Management of the affected patients depends on the level of visual disability, and you can organize it according to the tectonic thing that you're planning for. Either the patients can undergo a cross-linking or intracorneal ring segments, or partial thickness LK or DALK, or a large diameter PK. The corneal independent interventions can be again spectacles, or initially RGPs, later scleral lenses. And in fact, toric IOLs have been described as a method to handle the astigmatism in PMDs also. Now these are the other innocuous, relatively innocuous in comparison to what we have already described. This is a crocodile shagreen. So the surgeries that you will be doing will be fairly regular. It is only the visibility which you have to deal with, like Dr. Mona will be describing in her surgeries with corneal scarring. This is a central cloudy dystrophy of Francois, in which you have the shagreen more in the center. So this is not a dystrophy as such which requires any kind of intervention for the corneal side. This is a senile furrow degeneration. Arcus, you have the arcus senalis deposits forming a ring in the periphery, and what is important is that there is a clear zone separating it from the limbus. So mild thinning may occur, but you can be, once you're sure that it is not associated with any collagen vascular degeneration, you can go ahead with the cataract surgery in the regular fashion. Another thing which is not strictly a corneal degeneration, but because it extends onto the cornea, is when you have a pterygium encroaching onto the corneal surface. So if it is atrophic and there's not much of fibrovascular degeneration, then you deal only with the cataract, like in this case. When there is an atrophic pterygium, but there is not much of astigmatism, then you can deal only with the cataract as such and leave the pterygium alone. But if it is affecting the, if it is increasing the corneal astigmatism, and then you need to do a sequential, a staged procedure in which you do the pterygium excision followed with the autograft and the fibrin glue, and later once the surface is stabilized, then you deal with your cataract surgery and you go ahead with your intraocular lens implantation. Oh. So now, so we will be skipping this part in which cataract surgery has been done in a patient after a patch graft. This patient was a patient of secondary Sjogren's syndrome associated with severe dry eye, and she had a sterile melt several years before she presented for cataract surgery. So she underwent a patch graft, and after that the corneal surgery, after that the intraocular lens implantation was done once she developed a cataract. So you can see the area of thinning in the periphery where the patch graft was done, and all the techniques described to improve visualization have been employed in this case also. The key is to optimize the corneal surface prior to cataract surgery and then going ahead with the intraocular lens calculations. Now patients, now we deal with the one which we most commonly see in our clinical practice, patients with keratoconus requiring a cataract surgery. Now they have unpredictable results and have an increased risk of a hyperopic refraction postoperatively. So a lot of IOL formulae have been compared, and I will be quickly coming to that. We will be coming to the intraocular lens. This was a 74-year-old male with a stable keratoconus. The most important is to ascertain the stability of your original pathology before you deal with your cataract. So we went ahead with the IOL power calculation using the Keynes formula, which is an AI-based formula. We will be discussing that later. And after that, the cataract surgery was done in a fairly regular way. What is important is that the toric IOL implantation has been done in this case once we have made sure that the keratoconus is stable and it is not progressing. As in every toric IOL case, it is important to remove the OVDs post-operatively so that the intraocular the stability of the intraocular lens can be ascertained. And here you can see that with this kind of formulae, your cylinder has come down from a minus 2.5 to a minus 0.5. Now, what is the problem with IOL power calculations? The normal biometric assumptions do not apply in patients who have keratoconus, because the relationship of the anterior and the posterior corneal surface is lost. You have an abnormally deep anterior chamber. You have a long axial length. So as it is, the intraocular lens power calculation is erring on the side of hyperopia. So you aim for myopia so that the patient ends up emmetropic postoperatively. The other thing is that you do not have a regular astigmatism. Your principal meridians are not orthogonal. So you have irregular astigmatism. What you're measuring is not the accurate K, and therefore the patient is more prone for refractive surprises. Patients need to take a contact lens holiday more for rigid lenses than for soft contact lenses. Now, as far as the IOL power choice goes, monofocals are most commonly used, like Dr. Sagar has described in his talk. We prefer to use lenses with a positive or a neutral spherical aberration rather than a negative, so that can be neutralized, that can neutralize the negative corneal aberration. Patients with keratoconus have a slightly negative spherical aberration, so you want to use a neutral or a positive spherical aberration lens. Toric IOL calculations are less reliable, and but if the condition is stable, then you can go ahead with the toric IOL implantation. The rule of thumb is to see whether the patient is dependent on contact lens wear in his daily life. If the patient is dependent on contact lens wear and he's likely to wear the contact lenses after the surgery also, then you cannot go in with a toric intraocular lens, because the contact lens will neutralize the astigmatism on the corneal surface, and that leads to unmasking of the cylinder in the IOL, in the toric IOL. So you will end up with more cylinder if the patient is, and it is challenging to fit a patient who has undergone a toric IOL implantation in a keratoconus. So if the patient is dependent on glasses, you can go ahead with a toric IOL implantation, because you know it's a mild to moderate keratoconus. Multifocal IOLs, I think, is just asking for trouble in these cases, because multifocal, the results are dependent on achieving emmetropia, which you are not ideally likely to achieve. And these patients also have relatively high amount of higher order aberration. So the pearls for cataract surgery in keratoconus are that you ensure KC stability prior. You can do either the CXL or the graft, whichever is required, and later the IOL when the condition is stable. You need accurate biometry machines for rapid acquisition, so that the tear film also does not contribute to errors preoperatively in the biometry. You need to assess the patient's dependence on contact lenses postoperatively. Incisions we have already described. Sclerals are preferred rather than the corneal. Standard approaches lead to hyperopic surprises, so we need to aim for myopia. The K in keratoconus formula and the Barrett True K KC. These provide accurate results, and you need to manage the patient expectations. So the surgical planning needs a multifaceted approaches, and these are the few reports in literature. Now the IOL formula, the K in keratoconus formula, uses a modified corneal power, and Dr. Kane has described that when there is mild keratoconus, you need to target 0.5 diopters of myopia, 53 to 59 moderate keratoconus, -1. And when it is severe keratoconus, in fact, some of the papers by Dr. Watson, BJO, there's a report, you can in fact use a standard K, because there is a fallacy with all the IOL power calculations. The Barrett True K KC uses a double K method. The first K is the measured K, which calculates your IOL power, and then there is a theoretical K, which is used to predict the effective lens power. Holiday 2, unfortunately, it comes up with a lot of errors. So it's either the Kane keratoconus formula or the Barrett True K KC. These are freely available online, so you can feed in your values into them and end up with, and we encourage you to use these formulas for when you're calculating your IOL power calculations in keratoconus patients. Thank you.
I would like to thank Dr. Aditi for such an exhaustive talk. Now I would like to invite Dr. Rishi for speaking on cataract surgery in endothelial keratoplasties.
At the outset, I'd like to thank Dr. Mona for involving me in this lovely IC. All the talks have been really good, and I hope you find this useful. So the topic given to me is cataract surgery in endothelial keratoplasty. So it's very focused topic, and I'll try and just give some of the important tips when dealing with the situation of a cataract in a patient who's either already had an endothelial graft or is in need of an endothelial graft simultaneously with the cataract surgery. So I'll describe both the situations. When you're talking about a a combination of a cataract surgery with endothelial graft that is called an EK triple, and that could be a combination with either a DSEC or a DMEC. The first situation is cataract surgery after an endothelial keratoplasty. So either the patient has had a DSEC or a DMEC. If the patient has had a previous DMEC, the surgery is pretty much just like it would be in a virgin cornea. You don't really have to make any separate things, except that your endothelium is precious, so you want to preserve the endothelium. So the approach to your cataract surgery will be like it is for any patient with a maybe an endothelial deficiency like a Fuchs. So you will probably use a soft shell technique or a viscoadaptive OVD to protect the endothelium, and repeated injections of OVD in between your steps of cataract surgery. Ideally, you would like to make your entry outside the DMEC graft, but I don't think it's mandatory. It's very unlikely that your phacoemulsification will detach the DMEC graft. Rest of the surgery is pretty much normal. Even IOL calculation in DMEC, you don't really need to make much of an adjustment because it doesn't really have much of a refractive effect, the DMEC graft, unlike the DSEC graft, which causes a hyperopic shift, so you have to choose a more of an endothelial, more of a myopic power. When doing phacoemulsification after a DSEC, you have to keep some things in mind. One is your entry wound. So if your graft is well centered, then probably it may make sense to do a scleral tunnel, and always try to enter outside your graft. If it is a decentered graft, choose the side where you have more working space, so that your entry is away from the edge of the graft or away from the DSEC graft per se. Sometimes you will have some posterior synechia or peripheral anterior synechia in DSEC, and it's important to use this opportunity to also release those attachments. Otherwise, sometimes after surgery, those synechia can increase, and it can even trigger a graft rejection. When you're doing the rhexis, sometimes the visibility may not be very good, and it's important to get a good rhexis. So, especially if you have some interface haze or any irregularity in the graft. So, don't hesitate to take off the epithelium if that helps to improve your view. You can use other illumination techniques like the endo illuminator, like was mentioned by the previous speakers, and use of repeated dispersive OVD on the surface of the cornea also would help. Rest of the steps of phacoemulsification are routine, except that again you want to approach this case like a case with a precious endothelium, because it is precious endothelium. You have an endothelial graft there, and we know that even if the graft is clear over time, most of these corneas do lose a lot of cells, and sometimes you may have a clear graft with as low as 500 or 600 CD count. So just try to do an in the bag slow motion phacoemulsification, repeated injections of OVD. Try to direct your phaco tip away from the endothelium, so you might want to just either face it downwards or sidewards, and make sure that every time you're introducing your phaco probe, try not to go in with irrigation on. Sometimes the flow of your irrigation can also detach the edge of the graft, which is something you just don't want to end up with during a phacoemulsification in a post-DSEC eye. The other thing to keep in mind is in case this patient is going to likely require another endothelial graft in future. So this is just to show that sometimes if you can't see well, don't hesitate to take off the epithelium. So I could see, but I was a little unsure when I was doing the IA. So rather than have a PC rent because of poor visibility, I'd rather just take off the epithelium and let it heal later. So that's what I did in this particular case, and you can see the visualization suddenly got a lot better. So in this case, I'm using a silicon tipped IA probe, so it's very gentle on the capsular bag. So even if you accidentally catch something, you won't really rip the PC. These are disposable IA tips. Intraocular lens, keep in mind that if this patient is likely to require another DSEC or a DMEC in the future, you probably want to avoid a hydrophilic acrylic lens. In this particular instance, I'm actually using a hydrophilic lens, but in general, it's a good idea to go for a hydrophobic or a non-hydrophilic lens, because hydrophilic acrylic lenses, when they come in prolonged contact with air, they tend to have calcification, and often this calcification is bang in the center of the optic, and that will affect the vision of the patient, and sometimes you have to go and change the lens. So it's really an exercise in futility, and you probably are best doing a hydrophobic lens. And the second thing is the IOL power. Like I said, always choose a little myopic power, because the shape of the DSEC lenticule is like a concave lens, and it will induce about 1 to 1.5 diopters of hyperopic shift. So that's about cataract surgery in a patient who's already had a DSEC. When you're combining with triple procedure, so it could be a DSEC triple or a DMEC triple. Some important points: remove the epithelium to improve your visibility, like I showed in the previous this thing. So don't hesitate to do that. Always use a cohesive OVD in a triple procedure, in an EK triple procedure, because if you leave dispersive OVD in the AC, it can prevent adhesion of your endothelial graft, and the dispersive OVD can come in the interface and even cause haze. So that's a very, very important thing that you have to keep in mind. Descemet membrane stripping is not really necessary in a PK, post PK eye, like in this case, but in a routine case, of course, you probably want to do. So this is a failed PK for a therapeutic graft in which we did a DSEC triple. IOL power adjustment I already mentioned. DMEC, aim for emmetropia. If it's a DSEC or DSAK, aim for slight myopia, about 1 to 1.5 diopters. And like I said earlier, avoid hydrophilic acrylic lenses because of the risk of calcification. So I'll just show some videos. So you can see this is a patient with pretty bad hazy cornea. So Fuchs endothelial dystrophy with cataract, and we're doing a triple procedure. So you can see, because visibility isn't so great, it's a good idea to actually take off the epithelium in such a case. So we put in the OVD, but can't really see so well. So we took off the epithelium, and then you can suddenly start seeing a lot better. You can suddenly all the details of the cataract are visible. Now, one more important thing to do in these cases is, if your visibility is still not great, don't try to do an in-the-back phacoemulsification, because anyway you're changing the endothelium. So pick up the nucleus pieces, bring them right next to the endothelium and emulsify them there, because it doesn't matter. You're going to change the endothelium. You don't worry about the endothelial damage in this particular instance. And again, hydrophobic acrylic lenses are better than hydrophilic lenses, and you have to do a good removal of the OVD, avoid the cohesive dispersive OVD, like I said. So after you've put in the lens and before you take off the OVD is when you actually take off the Descemet membrane. So in this case we are using a reverse Sinski hook to just core and strip the Descemet membrane. You can see it coming off. It's a good idea to mark the surface and do a well-centered removal. In this instance I didn't do that. I like to do a push-in DSEC, but you can use whatever technique you like, including pull-through or even tachofold. So I just put like a blob of OVD and slide it into the AC through a clear corneal incision. And after the graft has been attached with air, you can do these kind of venting incisions to remove the interface fluid and allow for good attachment of the graft. You can even center the graft through the venting incisions. Okay, you can also combine your DSEC with a manual small incision cataract surgery if you've got a really hard cataract. So that's what I'm doing in this particular case. It's a grade 4 cataract with Fuchs. So again, removing the epithelium to improve the visibility. You can see it's almost a brunescent to black cataract. I think it's a cataract and nigra, in fact, yeah. So you can see that I've done a large rhexis, prolapsed the superior pole of the nucleus out, and then basically once you've, in this particular instance I took off the DM first, but you could also do it after your intraocular lens is implanted. So this video should have come earlier, and then the nucleus removal. And then finally, after you've implanted the lens, you put in your DSEC graft. In this instance, I'm pulling it in with the forceps, but from the same side. So it's like a push-in DSEC. Finally, coming to the DMEC triple, again, principles remain the same. You sometimes may have poor visibility, so whatever steps you need to do to improve your visualization, use of an endo illuminator, removing the epithelium, etc., you can do. As you can see, I'm doing that now after I've partly done the phaco removal of the nuclear pieces. I'm doing the cortex removal with better visualization after removing the epithelium. Sometimes as you go into the cataract surgery, the cornea becomes more hazy and you may need to remove the epithelium later because it's become more hazy and you can't see anymore. So in this instance, after implanting the lens, I'm taking off the DM. You can see it quite clearly in this video. And after that, basically, you put in your DMEG scroll. Okay, so you can see that the scroll has gone in. When you've injected, make sure you give some counter pressure before you remove your injector, DMEG glass injector, because otherwise the DMEG graft can follow it and you'll suddenly have a graft outside the eye. Then you have to do all these tapping maneuvers which are typical of DMEG to kind of try and unscroll the edges of the graft. The graft is always endo out, so the edges can be curled in and sometimes that can be a little bit of a challenge. So in this case, we are pinching the center of the graft with one cannula and using tapping or decompression maneuvers to kind of unfold the edges of the graft and gentle tapping to recenter the graft. So you can see there's a mark, F mark on the graft as well. So once your graft is fully unfolded, you can go in with a small 30 gauge cannula, put in a small bubble of air, and then you basically enlarge that bubble in 2 or 3 small steps. You don't have to come out. So once the whole graft has been covered, then this is a good way to kind of make sure that the air doesn't leak out. You put it tangentially to the side of the side port, and that kind of closes your surgery. So cataract surgery in the setting of endothelial keratoplasty requires special attention and specific modifications to standard technique to have a safe and effective outcome. Pay attention to selection of lens power, material and design. Respect the graft and endothelium while performing cataract surgery after any keratoplasty. Thank you.
Videos. Now, I would be presenting on cataract surgery in corneal scar. Yeah, so patient selection is of utmost importance in these cases, which begins with the best corrected visual acuity, history of any recent decrease in vision in these patients, the visual potential assessment by doing a PAM or electrophysiological tests, or the need for any additive procedures during surgery like sphincterotomy, optical iridectomy based on the pupillary size needs to be decided, and the location, of course, the location of opacity. Despite doing careful pre-op assessments of uncorrected and best corrected spectacle visual acuity, it's sometimes difficult to differentiate the degree of blurry vision is attributable due to the cornea or due to lens. So here comes the role of RGP over refraction. If a RGP over refraction does not improve the vision at all, the likely culprit is the lens. Or if it improves vision, the likely cause is in the cornea. IOL power calculation is a major challenge in these situations, as we have seen earlier. So accurate axial length measurements can be done by optical biometers or A-scan ultrasonography in some cases, either by immersion or contact applanation techniques, B-scan in some of the cases where these two doesn't apply, by AB scan mode. The next major challenge is calculating the keratometry, which is sometimes very difficult because of irregular Myers. So one has to resort to pentacam imaging, used the case from the pentacam for these challenging cases. Patients with irregular corneas do tend to have hyperopic surprises, so one should err on the side of myopia And one needs to counsel these patients about the risk of refractive surprises and the need for glasses, contact lens wear, or even DBR surprise, which can result in IOL exchange in such scenarios. So that coming to the type of IOLs, zero asphericity lenses are best suited for these conditions wherein the corneal asphericity is affected. So a three-piece IOL in the sulcus where there is inability to visualize the capsular excess edge or posterior capsular rupture, multifocals are best avoided. Toric lens are basically suited in cases of corneal opacity with regular astigmatism, and in eyes with paracentral opacity is better to avoid a IOL with small optic diameters. Some of the intraoperative aids are avoiding the site of incision at the site of scar, using coaxial illumination as we will see in the further videos, and viscosurgical devices for improving visualization and increasing magnification, use of pupil expanders in the form of iris hooks or BX rings, dyes for improving the anterior capsular visualization, endoilluminators as we have seen in the earlier videos. Surgical technique relies on the relation to the opacity. One needs to decide about the site of incision. Capsular excess modification can be done by using higher magnification by placing OVDs, and even manual rotation of the globe when one needs to see the site of rexes in case of these scars. So another modification that can be done is using coaxial or retroillumination of the microscope during surgery, and use of endoilluminators, and use of IVTA in cases to identify the presence of vitreous in the anterior chamber. This is a short video. This is a cataract surgery in corneal scar. So I'll be covering the following case scenarios in my video. First comes cataract surgery status post-fungal keratitis scar, where a quiescent interval of 6 months was kept. There was a corneal scar involving almost half of the cornea with posterior synec and a complicated cataract, where irrigation cannula was used as an aid to release the posterior synec. Then the posterior attachment to the cornea was released using scissor, followed by iris hooks application and application of a trypan blue dye inside. Capsular excess was initiated and completed using intraocular scissors and rexis forceps. The enlargement was done using a rexis forceps here. Rexis margin continuity checked with an endoilluminator. Scleral tunnel made and phacoemulsification performed. Viscoelastic to improve magnification and increased visualization. Use of retroillumination to complete epinucleus and cortical removal here. Because the view becomes quite hazy, and unless we use a endoilluminator, it's difficult to even delineate the rexis margin at the end of surgery to decide for the type of IOL. Here bimanual probes used for cortical aspiration. The rexis margin checked for continuity, and then a 3-piece lens and a watertight closure. Here we achieve an outcome of 6.9 with minus 1.5 cylinder. This is a cataract surgery in post-viral scar under antiviral prophylaxis. In a central scar with a severe aqueous deficiency dry eye, where punctal cautery was performed after cataract surgery. Both the upper and lower puncta were cauterized till complete charring achieved. Post-operatively, this again cataract surgery status post corneal scar, where the site of graft was avoided, a temporal incision was made, phaco was performed. So to conclude, addressal of ocular surface issues, one has to resort to even shame plug imaging for calculation of DBR, addressing with punctal cauterization or plugging excision of the lax conjunctiva and presence of conjunctival calluses, to avoid excessive irrigation during surgery, to avoid the site of scar and plan incision away from that site, use of pupil expanders, use of capsular stains for improving visualization, viscoelastic for improving visualization and magnification over the corneal surface, use of endoilluminators in microscope, and retroillumination in microscopes for improving visualization, avoidance of premium IOLs, watertight closure by being non-hesitant in taking sutures, and counseling these patients to use RGP lenses or spectacles post-operatively. Thank you. I would like to thank all the presenters in my IC for their wonderful talks and their videos. And I would like to thank the audience for coming in this first session of the day. Any questions? Otherwise, we will have a video, photo. फोटो कौन लेगा फोटो?